You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers. Welcome, Sky community. Welcome back. Today, we're talking about a topic that we really want to bring out into the open, vaginismus. It is a sexual pain disorder that involves involuntary vaginal muscle tightening during penetration, causing pain and discomfort. It can make using a tampon uncomfortable, going to the gynecologist and having a pelvic exam uncomfortable, and penetrative sex impossible sometimes. The exact cause is often unknown. We can have things like anxiety, past trauma, vulva pain disorder, childbirth injuries, even recurrent infections that could lend to this. So often it takes a multidisciplinary approach for us to treat this disorder. And that may be through pelvic floor physical therapy, working with a sex therapist, working with vaginal dilators. And we want to get into it today because so often patients are hesitant to take that next step and schedule an appointment with a sex therapist because, they're going to get into my business and this makes me uncomfortable. So today I have with me Rachel, who is a licensed professional counselor and certified sex therapist in private practice here in Texas. She's passionate about providing evidence-based therapy for a wide range of sexual dysfunctions and intimacy-related concerns. And she's currently working on her PhD in marriage and family therapy. And so we've been talking a little bit offline about partnered therapy and how that plays into vaginismus and improving pleasure and relationship satisfaction. Welcome, Rachel.
Hi, great to be here.
So happy to have you. So talk to me about how patients often find their way to your office and what your approach generally is.
Yeah, so I think sometimes when we think of vaginismus or even other sexual dysfunctions, we only think of the physical side of what's going on. And really, we want to take a biopsychosocial approach. And so the research supports multidisciplinary team. And so how can all of these treatment providers really connect and coordinate care together to get you the best results? And so many times people find their way to my office through a pelvic floor physical therapist. I often find too that because vaginismus can be so highly associated with sexual shame and specifically religious sexual shame, that simply word of mouth gets them here. You know, they have a friend or they have a church community or faith community that's told them, like, hey, I've gone to this person before and they were able to address this particular sexual dysfunction in lieu of my beliefs and some of the shame that's really impacted this part of my relationship. And so many times by the time they see me, they've been suffering for 2 to 10 years. So I find that many times they've gone through multiple providers to try and find the help they need, and many times dismissive providers that tell them to just relax or just do it.
Why?
Have a glass of wine is a super common one, and it's disheartening and disillusioning for them to receive that feedback, and in spite of all their efforts, in trying to find someone to help. And it's embarrassing. It's not, it's one of the most sacred parts of us as, humans, that we share this part of ourselves with people. So I think it's hard to take that first step.
Oh, I would agree. And then especially if you've been gaslit or you've been shamed in a clinical setting anyways, bringing it up again, I would imagine would be so terrifying. You might have a little PTSD from that, You're like, I don't know
Yeah.
how much I want to address this because I feel like nobody is taking me seriously. And you're absolutely right that our culture and religion, what we have been taught about sex or not taught about sex can really play into that. And we know, as you were addressing the biopsychosocial, I talk about this all the time when we talk about sex and pleasure.
Yeah.
Um, it's so important because once we've experienced that pain, then we anticipate the pain and we get into this loop of catastrophizing.
Yes, absolutely. And, you had mentioned or asked about what my approach is. And
Mhm.
I think the first thing that is so important in getting good care is a very thorough sexual assessment. And so
Mhm.
I'm spending, at least a few sessions just getting sex history, sexual education, history of masturbation, history of what your parents talked about, history of religious influences, sexual experimentation, of course, any trauma related to sexual experiences, and really checking in on what the medical and physiotherapy options that have been tried already. We want to really make sure that we're ruling out something, and getting an accurate diagnosis. Like, I can't do that part, but what I can do is offer support when we have the right diagnosis. And so I don't want to be treating someone for vaginismus when really it's something else. So once we identify that that's for sure what we're dealing with, and there's an emotional or psychological hang up that is definitely preventing uh, using dilators, preventing being in a position to even just be sexually expressive at all, because of that religious sexual shame that tells you that that's gross, dirty. Then we're able to decide on the appropriate treatment plan. So some of the modalities that I will use sometimes will look like EMDR, eye movement desensitization, reprocessing, where we're actually processing maybe a first experience or sometimes a pelvic exam that was early in life that was really painful, because we have that association and that memory network that, like, penetration means pain. And just like
Mhm.
you said, it's just a loop, and our body remembers that pain and that trauma. And so sometimes we're processing a first pelvic exam, a first time of using or attempting to use a tampon. Sometimes we're processing a honeymoon experience. Like, it can range, you know, it's quite a range of experiences. And then sometimes we're working on just really good sexual psychoeducation. We're doing anxiety work using CBT interventions. And one of the things that I've been looking at specifically in my own research is the use of narrative therapy, which is a newer modality that can be used with individuals, couples, or families, that really helps deconstruct some of the stories that we have written about ourselves,
And how
often
it can
gained,
play. Yeah.
yes, often gained from societal discourses like church, religion, other institutions that tell us things about ourselves, and really deconstructing those and the meaning that we've made from them, and really identifying that preferred story that we want to be able to live out, that there's a lot of obstacles that get in the way of doing that.
So you brought up a couple of terms that I just want to make sure that we're clear, that listeners understand, and that is
Yeah.
EMDR and CBT.
Yeah. So EMDR it was discovered in the 80s and is now one of the two approved treatments by the American Psychiatric Association for post traumatic stress disorder. So originally it was used for um, veterans coming back from combat. And it's a shorter term therapy where we actually use bilateral stimulation. So, eye movements that go back and forth, or pulsars that you hold in your hand that go back and forth, buzzing, to essentially mimic that REM sleep that we go into. When we're in deep REM sleep, our eyes are actually going back and forth, processing information from the day. And so it's really working on the storage of our memories and how our body holds on to those memories. And so, what we see with the protocols that we use in EMDR and the bilateral stimulation is this lessening or dampening of some of those body sensations or unpleasant emotions or unpleasant cognitions or thoughts that would usually show up when we're in that same environment or same kind of similar environment. We notice those actually dampening or going away completely. And so we're able to think about the things that we were once stuck in more adaptively and be able to see them differently. We're not changing memories, it's not hypnosis. It's, you're fully present. It's just merely working on the storage of how our body stores that memory. And so CBT is cognitive behavioral therapy, and that has been around since the 60s and really identifies those beliefs and specifically cognitive or thought distortions, that distorted thinking that ultimately forms our beliefs and influences our behavior. So it would look at identifying these automatic negative thoughts or distortions that you have over and over about sex. Sex is bad. When I feel sexual, I feel guilty. It's, you know, examining those beliefs that really hold you back from being able to, um, sexually express yourself, or even how you see your body, how you see or view sex. Period.
Yeah, I mean, I see patients often who either have always had difficulty inserting a tampon, all from the first time they ever had sex, had extreme pain, are unable to complete a pap smear. And while they can recognize that they feel like this isn't rational and they should be able to keep their legs open for their pap smear, they're clenching it down, and they feel like they have no control over it, and they're constantly apologizing. And I have to try to help them, because I don't want them to feel like they need to apologize. They feel like it's so simple, so on the outside looking in, they're like, I should be able to do this is such a simple task, but they cannot, because their body, for whatever reason, it's this automatic response. And
Hmm.
so there's that's some physical aspects of kind of what we see, or even just with a digital exam. So just a finger placed on the pelvic floor muscles, we can feel these tight
Right.
muscles, and intense pain that they experience. And they may say, yes, this is what it feels like, or this is reproducing that pain that I experience. But from a psychological standpoint, what are you seeing that patients are often experiencing because of this? We mentioned
Yeah.
shame.
Yeah, they experience a ton of shame, a lot of anxiety and fear. Um, some of my clients have talked about just fear of penetration, anxiety, lots of shame messaging, like, my husband's going to leave me, my partner's going to leave me, my femaleness, I guess, is under attack. Internally, they internalize a lot of these messages, and this can lead to even fear of pregnancy, fear that they may never have a child if they can't get, over this. And then even when presented with treatment options that are fairly, positive and promising, the prognosis is positive. They struggle with the motivation to use dilators and struggle with the motivation to do the work because there's so much, I think, shame tied to it, but also one of the things that I've talked about before with clients is that it's just not fun. It's kind of taking the fun out of this thing that was supposed to be pleasurable. And so doing this work just feels so laborious to them.
Yes, I could see how doing the work feels probably isolating and time consuming, and you're right, not fun. And so let's talk about how you even use a vaginal dilator, because I think some people may be like, wait, what? Yes, this gives you control to use a vaginal dilator, which is exactly like it sounds. It has a set size and depth, and you are in control of placing it, and it has incremental sizes. So you can use the size that is comfortable to you at that time, and you insert it slowly and gently with lube on it, and you stop when you feel pain, and you let it stay in place for 10 to 15 minutes, and you do this a couple times a week. And then we go to the next size when we're tolerating that. And you may feel like, who's got 45 minutes a day for this kind of is this really going to work? And I think that's where the mindset comes in.
Yeah, absolutely. I think in general, many women are, you know, working full time. There's fatigue already that they're fighting. I mean, fatigue is one of the number one reasons we see sexual desire, decline, that women are just tired and they don't have the mental energy. And it's already something that is associated with pain, with low self worth. And what I find is that the more that we can bring the partner into this process, the better. Women benefit from having a supportive partner who says, like, hey, this isn't just your problem. This is our problem. And it's not a problem with you. It's a problem that we're fighting together, like, as in we're going to externalize that problem, that like we're fighting against vaginismus together. You are not your vaginismus. You are not your sexual dysfunction. And I think the same thing shows up for me as a sex therapist when I'm working with a couple where the male partner is dealing with erectile dysfunction, premature ejaculation. Like, we need a supportive partner. This is a mutual activity that requires and longs for connection. And so when we limit it to just, hey, this is your problem and good luck, and hey, I'm here from afar. Yeah. And when you're done, like, we're going to have great sex. And that is not always what we see happen. We might see penetration with good dilator work and following the protocols, but the pleasure and the connection would be missing, because really during that process and working with a couple, they're learning that intimacy is not just intercourse, that there are many ways to experience closeness and physical intimacy with your partner. And it's really an opportunity to explore that and expand that. So then when penetration is possible, they have a much richer and fuller sexual experience and intimacy experience. So it's really an opportunity for the couple to learn together how to expand their definition of good intimacy.
I think that's such an important point because it absolutely affects your sexual experience and your relationship. And so talk to us about how partners can incorporate into vaginal dilator therapy if that's what their partner's doing, or pelvic floor physical therapy. How are they, or even their sex therapy, how do they show up supportively? What does that look like?
Yeah, I think one of the first things that they could do is just coming to appointments, showing up for those appointments when they can, making that a priority, that like, I'm not just here for you, from afar when you get done with your appointment, but I'm here with you to learn. I think them doing their own research, them making a part of like, hey, I'm in this with you. And so that means I'm learning too. I want to learn about your protocol. I want to learn how to be in it with you, whether that means like, hey, I'm going to wash the dilators for you after you use them, or I'm going to help prepare the atmosphere that's relaxing, or maybe give you a massage, or um, do some just light sensual touching, or maybe even it means like, hey, we're going to watch, a funny sitcom while the dilator sitting in there, and we're going to laugh and just create an atmosphere of just closeness, humor, that we're doing this together, that you're not alone in a room with, a dilator, that it may or may not go well. Sometimes you try a new size and it doesn't work. And that's really discouraging. You go back to your previous size. So having someone there that's your cheerleader and encouraging you and saying, like, you know what, it's okay. It didn't work today. We're gonna try again. Let's do our best. In the room, when we're talking about sex therapy, I think not only are they supporters and encouragers, but they have their own pain and grief about what's going on too.
Sure, right. Everybody has
So
their own unique experience in the relationship for sure.
yes. Yeah, so I think many times it's important for them to have support as well, and learning as a couple, how do we anchor one another when the other is dysregulated or frustrated or grieving? How do we hold space for that? How do we offer emotional support and attunement to one another without taking it on? Right. So that's the challenge. Like when he's grieving about, the fact that we haven't been able to have penetrative sex yet. How can I hold space for that without shaming myself or making it about me? That's a challenge.
Well, and I think that also as I'm sitting here, processing this with you, I'm thinking, is penetrative sex the ultimate goal?
I mean,
I mean,
considering so many women don't even orgasm that way,
right.
not
I mean, I kind
really,
of tease that only men orgasm through penetration. I mean, it is a
right?
very rare uniform of a female who
Small.
has
Yeah,
an orgasm through penetration. So, yeah, I mean,
absolutely.
I think that what's your ultimate goal and where do you reach that level of intimacy? I mean, obviously there's fear, there's anxiety, potentially past sexual trauma that we have to work through, and this lifetime of negative experiences, whether it's through childbirth or I mean, I've had women who it's been 5 or 6 years since they had their child and it was such an awful experience that they haven't gone back to see a gynecologist.
Right. Yeah.
As well as, anxiety disorders if you've experienced any pain, and then here
Mhm.
we go. So, I think that it's just so important that we take this multidisciplinary approach, but also involving a partner in this, I think is wonderful because then you guys get to decide what does success look like for you? Now, it's one thing if it's creating pain and discomfort for an individual who's just going about their daily life, right? Or if they just want to be able to use um, feminine hygiene products for their periods and they're
Mhm.
unable to. Like, I get that that's so incredibly hard. Or just get their necessary annual exams.
Right. And
There's
sometimes that is the goal. That is the only goal. Sometimes penetration is not on the table for various reasons, and that's not important to the partnership. But for women to receive good sexual health care, they do need a pelvic exam, or they would like the convenience of a tampon. And so, I think overall, my goal with couples in a sex therapy office is connection. Like, how do we reframe intimacy as connection, not even climax focused or intercourse focused, but if is this activity that we're doing, are we connecting? And beyond just that, like dopamine connection of the high, but also really leaning into that oxytocin connection of like, this is this long lasting, love hormone kind of intimacy that is multifaceted. It's emotional, it's sensual, and sensual is just that kind of touch that's about pleasure, not arousal or orgasm. And then there's also that erotic intimacy that is about arousal and is about orgasm. And so, how do we bring all three of those things together and just really value and prize feeling seen, feeling heard, being known, regardless of what the goals are.
Sure. I mean, I think developing a positive body image and self-esteem despite vaginismus
Right.
is really key.
Absolutely. Yeah. And even in when I look at the recent research, and so when I say recent, last 5 to 10 years, we're not seeing sexual trauma as being the primary factor or presence of sexual trauma when it comes to vaginismus. We're
Okay.
seeing things like rigid religious upbringing, sexual shame, poor sex education. There's a difference between what we see in like westernized countries and Eastern countries, and Eastern countries present way more vaginismus. And I think one of the things, or at least one of the reasons why I've really looked into how religious sexual shame shows up is because there's not as much research on that kind of shame as just general sexual shame. And when we look at even a study as recent as 2024, 400 female participants, researchers found that distorted beliefs about sex and presence of shame predicted over 50% of their sexual dysfunctions. And so, really examining that piece, I found is necessary and vital to the sexual assessment process. Many of these women who've grown up in those environments, they have been taught to view sex as a way to pleasure a partner versus receiving pleasure. And so their own pleasure is on the back burner or maybe seen as unnecessary. And that's when I have women showing up in my office that say, I could take it or leave it. Like, if I didn't have sex ever again, I would be fine, you know, or if we didn't do this, I would be fine. If it wasn't for the fact that I wanted a baby, I don't think I would care that much. And they've kind of learned to devalue or dismiss or repress
Yeah, they
their
just
own
fake it. They're
sexuality.
just having
Yeah.
duty sex. They're not
Yeah.
necessarily doing it for their own
Yes.
pleasure.
The obligatory and duty sex kills sexual desire. It's the
Sure,
worst. And
sure.
so, even these women who are presenting with vaginismus, while they may not be having penetrative or, penis and vagina sex, they're having some kind of uh, intimate encounter. And even that feels fake or overwhelming or dutiful or about my partner, because for me, I could take it or leave it. So there's a disconnection between mind and body, and that's where things like EMDR can really help. Some of those
Sure.
somatic approaches can really help to reconnect the mind and body. I think that's the benefit of having a few modalities that you can try, and different modalities appeal to different clients. So different
Yeah.
minds. Some people just really soak up the cognitive stuff and that speaks to them. And other people really need some more body work to really get in touch with, how do I reconnect to that? Or maybe I've never connected to it before ever. So how do I connect to that for the first time?
So we've focused a lot on vaginismus, but I just want to say that, vaginismus is not the only sexual pain disorder. There is a fabulous book called When Sex Hurts. This is one of my favorite reads. It's written for the general public, but it's also pretty dense, and I learn things from it. And I'm oftentimes messaging the author and being like, holy cow. How did I miss this in OBGYN residency? So this is a great read, When Sex Hurts by Andrew Goldstein, Caroline Poolcall, Erwin Goldstein, and Jill Crabb. So fabulous read. You can find it on Amazon, I'm sure. Let's talk about what resources are available for individuals and couples experiencing vaginismus. I mean, are there online support groups? What are you seeing?
Yeah, there's a great support groups out there on Facebook, support groups. There's a organization called Hope and Her that has completely overcoming vaginismus book. I'm a huge fan of When Sex Hurts, the book that you just recommended, and I believe it's Erwin Goldstein. He provides I want to say a 5 to 10 minute phone consult that's free, even if you're not, in the state of California. I think he's still in San Diego. Um, when some of those pain disorders get a little bit trickier, or maybe you've visited other OB-GYN offices and they were unable to help you, or it was baffling to them in some way, that as a sexual medicine doctor, he can provide some resourcing, or I've even had him recommend local doctors that he knows in the area, like UT
So
Southwestern.
guide, yeah. So he's
Yes.
more
And
guiding
so,
you, like doing a consult of like, what have you tried and where would I
yes.
recommend you go next without treating
Yeah.
you? Okay, and that
Right.
brings me to an important point because they are very heavily involved in the International Society for the Study of Women's Sexual Health,
Hmm.
ISHWISH, and they ISHWISH actually has a patient website. It's called Prosala, PROSAYLA.com. And it's got tons of information there. Lots of great blog posts written by other physicians with just chock full of wonderful information.
Yeah, there is a lot of information out there, lots of books. It's getting more and more attention, and sometimes I think that can be a little overwhelming. And so I encourage clients, start with one. Um,
Yes,
it
yes,
can
of
be
course.
tempting to get all of them, or get all of the things, because you want so badly to find help with that. Some of the resources that I recommend to clients, specifically coming from that religious background and struggling with the religious sexual shame, is one book by Rachel Joy Welcher called Talking Back to Purity Culture. She does a great job of taking each of kind of the overarching themes of purity culture and um, processing through that. There's another book called Pure, and that is by Linda K. Klein, and same kind of thing, where she's talking through some of those challenges and the repercussions. I think for a lot of my clients, when they read those books, they feel really seen. They feel like, oh my goodness, I'm not the only one, and that in and of itself can help decrease some of the shaming messages. Shame tells you that you're the only one, and so I think that you can find community resources. I think it's really hard to talk about it because it is so private. And so some of those community support groups are a good place to start, because it's not necessarily something you're going to bring up, when you lunch with the ladies, or, um, just hang out with friends. Most people are suffering alone. Honestly, these couples are just kind of doing it alone and reaching out to providers, but really we heal in community. And so I think the sooner you can find community, the better. And then usually community is leading you to the great providers, and they have their own resources, or maybe they're a little bit ahead of you in their journey. And so they can just give you a ton of hope on, like, hey, I've been where you are, and like keep going, or this really helped me.
Yeah.
Use
Because,
dilators.
right, because it can resolve.
Yes,
So I
yes.
think that that's
And
important
that,
for us to say.
yes,
It's not a
that
lifelong sentence.
No, I think that that's maybe the puzzling thing, and the area where I think there's a lot more research needed, is that even when we have a solution, and you'd be better at telling me the percentage of this, but vaginismus is essentially curable, so we're able to see people successfully have penetrative sex if that is on their list of goals. But even with the solution in front of them, women are still choosing not to use the dilator protocol, or having such a hard time with motivation. And the fact that I see that so much tells me, like, there's something there. There's more there that we don't understand, or we don't completely see, that so many women are just struggling to even start the dilator work. And how can
Right.
we help them and support them and
Yeah.
champion and empower them to do this so that they can get on the other side?
So I'm just doing a quick search and I'm finding anywhere between 90 and 100%, 90.3 and 100% in terms of resolution with multiple modalities in vaginismus treatment. So the fact that it can be cured, I think, is enormous. Like,
Yes.
let's be of good of hope, that this can resolve. And it's just a matter of finding the right combination for you and helping
Right.
you to feel confident in your body.
Right.
Well, tell
Absolutely.
everyone how they can find you, Rachel.
So I work for a group practice called Aspen House Associates. We have an office in Richardson, Texas, and we also have an office in Mansfield, just south of Fort Worth. But we also offer virtual sessions, and so we can do everything virtually, including EMDR. So you can find me by going to aspenhouseassociates.com, or you can email me directly at rhenning, Henning, at aspenhouseassociates.com. And Aspen House is ASPENHAUS. I'd love to help you on this journey and walk alongside you. And I love working with couples and doing that partnered work that just creates really a holistic view of intimacy and connection.
I love this approach. Yes. Thank you so much for joining us today and lending your insight. Until next week, be well.